Okay, thank you. Hi, everyone. My name is Melissa Hidalgo. I'm internal medicine resident physician, PGY2 at Broward North Hospital from Florida. So today I'm going to present about Troponinemia post atrial fibrillation ablation. Is this a suspected side effect or is it a perfect ACS storm? So a little bit about background. Radiofrequency ablation for atrial arrhythmias can result in increased markers of inflammation and myocardial injury. Inflammation is a significant contributing factor to the higher prothrombotic state early after cardiac ablation. Patients that undergo ablation for AFib, they have an increased risk of thromboembolic events, about 1.1%, especially in the first 2 weeks after they get this procedure done. So here we have a case of NSTEMI requiring cardiac stenting post-ablation for AFib. So here our patient is 71-year-old male with medical history of hypertension, hyperlipidemia, tobacco use, aortic stenosis, obesity, AFib on Xarelto. He was compliant at home. He was a status post cardiac ablation 1 day prior to admission. He presented with a complaint of orthopnea and non-radiating mid-epigastric tightness that started several hours after he got the ablation at night. So he got it in the morning and this started happening on the same day at night. Associated symptoms that he reported when he came in were nausea and lightheadedness. He reported no prior similar episodes. On admission, he was hypertensive at 173/96, but otherwise, other vitals were unrevealing. On physical exam, S1 and 2 were present, regular rate and rhythm, upper left external border systolic murmur as suspected because he had a history of AS, bilateral lower lobes expiratory wheezing, but no peripheral edema and no other significant findings on examination. EKG, I put it here. This was the EKG on admission. It was sinus rhythm, rate 88, some PACs, but no acute ischemic changes. For labs, they were significant for troponin level of 5.78. BNP was 191. YCAN was mild elevated, 12.85. CRP was elevated at 11.15. On imaging, we did a CT angio, which just showed cardiomegaly, trace pleural effusions, and bilateral interstitial infiltrates. This patient had a pharmacological stress test back, 1 year prior, which was negative. And 1 month prior, he also had a TTE, which showed mild concentric LVH, moderate severe AS, moderate left and right atrium dilation. EF was normal, more than 55%, and no wall motion abnormalities. During this hospitalization, we decided to repeat the echo because they had new findings. So, the repeat echo was pretty much unchanged. No change. Then we ended up giving him diuresis. Interventional cardiology was consulted. And on day 2, the decision was made to finally get cardiac cath. So this patient initially wanted to leave AMA and kind of just do cardiac cath as outpatient, but it was just concerning, because of the lab findings, the initial complaint. So he ended up having it done during hospitalization on day 2. So here we have the outcome on left cardiac cath. He ended up having a right coronary artery with a focal high-grade 90% distal stenosis that was stented. With a 2.2 by 15 millimeter drug-eluting stent, troponin levels ended up trending down. Patient clinically improved and was discharged on Xarelto and Plavix. So on conclusion, the elevated prothrombotic markers after patients get this cardiac ablation are associated with a systemic inflammatory response, which could explain the increased risk of early thromboembolic events that they can have after they get the procedure done. Further investigations targeting specific anti-thrombotic measures may further reduce post-procedural thrombolytic events, but that's something, there is no something set up yet. So here I put a question, which of the following would be a correct statement? So different options here. So A, prothrombotic markers reach the highest value at approximately 3 days and 1 week after ablation for AFib. Fibrinogen levels significantly increase from day 2 to day 3 and at 1 week after ablation. option 3, D dimer levels significantly increase from day 1 to day 28 with the highest peak and 1 week after ablation, or the last option is like all of them. So what do you guys think it could be the correct answer? A, B, C, or maybe all of them? So in this case, it's actually all of them. So it's kind of like I'm putting this question to emphasize about this inflammatory state that these patients have, which, you know, like I said, it can predispose them to have thromboembolic events. Maybe this stresses that the patient has was false negative. Maybe this was a complication of the ablation that he had done before. But, you know, I think the systemic inflammatory state is, you know, something that is contributing them. And so just wanted to, you know, bring this up and kind of like awareness for like all our patients that are getting ablations and they come in with troponinemia, just know like, you know, expected. I mean, it is expected, but kind of always, you know, to keep this in mind that it could be a perfect ACS storm. Thank you. Do you have any questions?
Thank you so much for your excellent presentation. Was the troponin level a repeat measure?
Yeah, so I went, so 5, then repeated was in the 3s, and it didn't go down after he got the ablation. That's when it finally went below 3, ended up being like 0.8. But before it, like, you know, the first 3, the regular 3 repeats that we did, it was above 3. And then on day 2, after he got the ablation, that's when it finally went down, 0.8, yeah.
All right, wonderful. Thank you so much for your presentation.